This is the case of 69 years old man. He underwent to surgery in 2013 for bladder cancer. During a follow-up, CT scan showed a 2 cm 60 lesion in the isthmus of the pancreas. An MRI revealed inside branch IPMN. USFNA was performed, and the analysis of cystic fluid taken during FNA showed high level of CA and normal level of lipase. The patient is scheduled today for US with confocal laser endomicroscopy with Dr. Saftoyu and Dr. Kayol.
So we just started the examination and we passed the endoscope. So first of all, the lesion was a bit difficult to reach. So we are now with the endoscope a bit torqued, and we are in between the first and the second part of the duodenum, so in the duodenal bulb, and you see the lesion already started. So I'll try to show it. So the lesion is here. So in order to see what are the vascular structures and which is the cystic lesion, then you can easily start the color Doppler. And you see that the lesion is very close to the splenic vein and actually the splenomesenteric confluence. Then we also have an artery interposed somewhere here, a small branch, but the lesion is here. So now what we have discussed is that we try to characterize a bit the lesion. So it's a combination of cysts. So it has multiple cysts, some septations, and we discussed a bit that in some, let's say, sections it might look like an IPMN, but it also looks like a serocystadenoma. It doesn't look like a solid pseudopapillary tumor. That's the discussion right now. So we can measure it. It's around 2 centimeters.
The position is not easy, yeah, because you are in the upper part of the head.
Exactly.
And so you have the scope which is pushing in the bulbus.
Yeah. But that's how we got the, let's say, the best images. And I mean, we cannot say using only grayscale imaging and Doppler, we cannot say too much about the cystic mass. But taking into account the characteristics, I would go more towards serocystadenoma or IPMN. The other thing is that, of course, the next question would be if we can use elastography. We can, of course, use elastography. You see that the images are really nice, reproducible, but what you see actually on the cystic lesion, it's a lot of artifacts here. Because of the cystic masses, you get a lot of tricolor artifacts. So actually, you see a lot of artifacts inside the lesion, which are also, let's say, an argument or a characteristic for cystic masses. So again, we have, let's say, an idea that this is a combination of small cysts.
Here you have, if you turn the scope, you have IPMN. If you turn it, you have a serocyst with a central tissue.
Yeah, so we were discussing a bit about confocal already, and we've discussed it also with Mark, and we decided that confocal would be really difficult in this position because the endoscope is already bent, so we'll have to pass a 19 gauge needle through an endoscope which is already bent, so the puncture would be really difficult. So it's a bit difficult to go towards confocal. So that's why the FNA has been done with a 25 gauge needle. It's a bit more easier in this position. What can we do now? I don't know if there are any other.
Maybe you can perform Sonoview to have the wall if a serocyst.
I mean, that's what we've discussed. I mean, we can perform Sonoview because serocystadenoma usually has highly vascular septations. So if there are no other opinions or if there are questions in the audience, we're happy to answer that until we change a bit the settings for Sonoview.
The problem of CLE is 19 gauge needle. Huh?
Yeah. Yeah. It's okay. We're not hurrying. So you see again the septations. Now we've changed to Sonoview, and just to explain a bit how the Sonoview examination works, you need a split screen. On the left side of the screen is the contrast harmonic imaging. So the one in the one in orange is the contrast harmonic imaging mode, and on the right side you have the normal grayscale mode. And you have to be a bit careful with the settings. So what we can do is to increase the mechanical index. I usually prefer to increase it to 0.2. And that's because we will look probably only on the arterial phase and the first part of the venous phase, so you only need 1 or 2 minutes for pancreatic examinations. So we don't care if we will destroy some of the microbubbles using a mechanical index which is a bit higher up. But if you want to get good images with a nice contrast, then you have to go with the mechanical index to 0.2. You can see it here on the screen on the pointer. So we go to 0.2, and then another parameter which is really important is the dynamic range, which should be 50 or 55. And then what you can do is we want to get rid of the signal from the tissue as much as possible, but you have to take into account that strongly hyperechoic structures like calcifications will give you signal also on the contrast image. But
do you have a trick when you don't see very well the US image?
Yeah, then we go to the right part of the image and then we increase a bit the gain. So now we have the grayscale image very nicely on the right part and the contrast on the left. And before contrast injection, you shouldn't see too much on the contrast harmonic imaging. So something like this. So we don't want to see too many structures, only some interfaces which are really hyperechoic. So you don't want to decrease the gain too much. So you don't want to do it like this because you won't see anything after contrast. But you don't want to keep it like this because now you get what Christoph was mentioning. So now you get signal also from the fundamental, the conventional grayscale. So
nice.
you have to keep the gain. Let's say we usually work with 5, so somewhere in between 0 and 5. You set up the gain and you keep it like this on the whole examination. So we want to see some signals, but very faint on the left side of the image. And then we can, I think, we can inject some contrast, please, if it's possible. So we'll mix some contrast. The contrast, as you probably know, is Sonoview.
Oh,
It's Sonoview, yeah.
Sonoview, yes.
It's Sonoview, not we're not doing the CLE.
I didn't.
So we will mix
we forgot to prepare it.
No, it's okay. we will mix the Sonoview now. So it's a microbubble contrast agent, and it's a blood pool contrast agent. So it stays in the vessels, and this is an advantage as compared to CT and MR contrast agents. And we have to mix it. So we have to shake it. The team here knows already how to do contrast, but you have to shake it very well because you need to do a lot of microbubbles inside the vial. And then we prefer to inject a whole vial for US examinations.
Which image will you choose with Sonoview? With you have to see a lot of wall, a lot of in the cyst?
Yeah, I would prefer to look at the wall and then concentrate if there are, let's say, mural nodules or other structures. But I would prefer to look at the thickened wall.
Okay.
So usually serocystic adenomas have a lot of signal inside the septations, and you nicely see the septations. But I wouldn't say that there are mural nodules here, so it's only a lot of cysts of various dimensions and some mural nodules. In order to differentiate a solid pseudopapillary tumor, a solid pseudopapillary tumor has both solid and also some small cystic spaces sometimes. It's a bit unusual because it's not a young female here.
Yes,
It's a male. But nevertheless, in order to differentiate that, we need immunohistochemistry or immunocytochemistry in solid pseudopapillary neoplasm, it's positive for beta-catenin neuronal specific analyze CD10, and so there are markers which clearly differentiate that.
We are ready for
So
Sonoview.
we're ready for Sonoview. So if you can place it, that's perfect. I mean, you have to place it directly in the not perpendicular because there are filters. So whenever we are ready, it's very important to coordinate a bit. So you can start, and then we can start. We started the timer. So now you see the timer already. The contrast is in, but you need to inject also quickly saline, because otherwise the contrast is somewhere in the tubing. Now you see the contrast already, so it started to show here a bit, but also in some of the now you see it here. It's the splenic vein, and we have to wait it a bit in the septations. It's not much,
No.
and now we
Do you
can.
ever use a flash?
Yeah, it's not
the
it's not a
septations, do you ever
flash.
use a flash?
We will use a trick that Christoph showed you. So we can use the microbubble trace imaging. So you see, it's not a lot of signals inside the septations. You see only the splenic vein here enhancing, and not a lot of signal here. So whenever you don't have a lot of signal, you can enhance it a bit. You can increase a bit the gain, but there's nothing much actually.
no enhancement,
There's no enhancement. So this is a bit against, let's say, serous cystadenoma. So whenever dealing with a cystic lesion or a cystic neoplasma, I'll try again with the microbubble tracing imaging. So you see, there are some faint signals here, but some of them are induced also by the hyperechoic margins of the septations. So you see it better now. There is some faint signal, but I'm not sure it's vascular or it's only the septations which give some echoes there. But whenever you have a low signal intensity, then you can use this mode, which is called microbubble trace imaging, which overimposes the images during the time.
So rather IPMN, maybe in the diagnosis.
So yeah, so now it's difficult, and when dealing with the cystic masses, you need an algorithm, and you have to integrate everything.
Yeah.
So you have to integrate cyst fluid analysis, contrast, CLE if possible, and of course final aspiration. So if there is a doubt and there is still suspicion of solid pseudopapillary neoplasm, I think we can
We have to perform biopsy.
we have to perform again, let's say, a 25 gauge needle aspiration, I would say. I don't know if there are other questions, but it's not enhancing.
Maybe in the part of the cyst when there is a tissue,
Yeah,
because we have
I-
CAA and lipase.
I have a question,
Yes.
Fabrice and Adrien.
yes.
A question about the choice of the needle. Why 25 gauge? Because in cystic lesion, maybe the cellularity in case of
Okay.
FNA with 25, it's a little bit low, no?
Yeah.
Why not Procor or,
maybe
I don't know.
maybe
22.
it's low, whatever the needle you use, no?
Yeah, I mean it's a, let's say, I don't think it's a lot of proof in the literature that 25 is better than 22, let's say. So in between 22 and 25, for cytology, there wouldn't be too much difference. If we want to obtain a cell block, then of course we can use we can try and use a Procor, or we can switch to a 19 gauge. The problem here is the position. So with a 19 gauge, it would be a bit difficult. We have some vessels, so you see that the needle will come probably exactly where the H letter is. So the needle will come from here, from the left side of the image, and we have a vessel here, and you can see it's enhanced. So we need to find let's say, a position for the puncture where we can avoid the vessel, I think. Maybe.
Yes.
So
You want
that's why we didn't take a Procor or a 19 gauge, because there are a bit more. So
you want CAA in the cyst and not in the blood.
Sorry, the CEA.
You don't want CEA in the blood, so you
Yeah.
avoid vessels.
So exactly, yeah. So I don't know if you would prefer. I would stick to a 25 gauge needle because of it's a bit more safer for the patient, let's say. But you see, it's not easy to get a good position. So we have it here probably, and it's quite important also to have somebody helping with the scope. So we'll try to get the needle. If we cannot get the needle, then we have to go back with the scope in the stomach and reposition. So let's try to do like this. Okay, so I got out of the stomach, and then let's do it maybe like this and get a bit out. Okay.
Perhaps we can have, while we're waiting from the audience, a show of hands for the size of needle. So who would use a 25 gauge needle in this case? Show of hands. Yeah, we're getting a few. And 22. Majority. And 19.
Why didn't we choose a
So
22?
22 was the favorite of the audience.
Okay. We can change if you want.
It's a democracy. It's a democracy.
We can change.
You want to change?
You're in charge, Adrian. It's fine.
No, we,
That's
don't,
okay.
we have no time. Sorry.
Yeah,
The chief is here and we have no time.
The chief is here, so that's it's always better for a democracy to ask the chief.
we
so
know,
that's
we prefer.
that's another
No,
option.
no, not yet.
Yeah, please.
Yeah, absolutely.
You have to perform the
That's a
biopsy.
true democracy.
This is my democracy.
Yeah.
Yeah,
So
yeah.
we'll try to reposition a bit. It's not an easy position for the puncture, but we'll try. Otherwise, we can go to another room and come back until we.
No, please.
We have time.
Proceed.
That's nice try, Adrian, but
I didn't get away with that.
I will see the
yeah,
other room.
you almost got away with that one.
Okay.
Interesting news. So sometimes with the needle in the scope, it's
Has anybody got any questions from the audience at all? If you have, put your hand up, please, so we can see you.
yeah.
So we can see the light. Look, the lights. You're all still there. Any questions? Yes, I have a question in the middle there for the microphone, please. Just the gentleman standing there.
Let me see if I can get it maybe.
We have a question coming very shortly.
Okay.
Could you just say who you are, please, and where you're from?
Yes, I'm from Qilu Hospital of China. Yeah, I have questions that why don't you just puncture the sixth part of the lesion and get some liquid to see if it's a mucus there. If it's a mucus, maybe if it's IPMA, if it's not, maybe a third.
Yeah, it's
It's
still
that.
better than.
Okay. So it was really a question about, would it be a good idea to get some fluid to see if it's mucinous?
Yeah, that's what we try, but it's not easy.
Can you see, Nick? Can you see?
Fantastic. Yes. That's a lovely demonstration of the test. So